This term was initially coined by Karen Haney, who was a medical doctor who later did psychology, and she was a feminist psychologist and quite renowned. So she focused a lot of her research on women and children, and regarded internalizing disorders as those disorders among children that cause them to move away from the world as against the world. That's the externalizing disorders. For this talk, we are going to be focusing on internalizing disorders, but when given some point, we shall look at externalizing disorders. These internalizing disorders consist of problems related to worry, fear, shyness, low esteem, sadness, depression. And if you're not keen, you may miss them out. You might have it, but you miss it out. Why? They are a bit silent. So these internalizing disorders happen to affect people softly, gently, but real. And we are at one by one to at how they manifest, the epidemiology, and how are they managed, and then what's the way forward? How can we lay a strategy to promote the good mental health of children, adolescents in the Eastern region? So primarily, they're influenced by cognitions. That's why the CBT approach is effective. CBT is cognitive behavioral therapy. The first one we are going to look at is anxiety disorders, and these have several types. We have generalized anxiety, which includes persistent and excess thoughts that lead to a state of distress and impairs the person's ability. Very, very important criteria. If somebody has a disorder and the functionality is not impaired, maybe it's not yet a problem that requires attention, but when it impairs the functionality, it becomes a problem that requires attention. So the other anxiety disorders in children is the recurrent panic attacks. These panic disorders, sudden increase in anxiety accompanied by physical symptoms like tensions, breathlessness, and dizziness. So you might even think a child is passing out, you know? Yeah, that's a common one. We have agoraphobia, fear of and situation that might cause one to panic and make one to be trapped or become fear places and not able to escape or get out of such a situation. Yeah. There is social phobia, the marked and persistent fear of social performance recognized by others and fears embarrassment of young people. You know. Then the simple phobias, persistent fear of an object or situation, or fear or reaction to such. Then we have the separation anxiety, marked anxiety, which relate to separators, often with a preoccupation of harm. So these are very common among young people, but we need to realize that some anxieties are developmentally normal. It happens. The 2 to 4-year-olds, most of their principal sources of fear stems from imaginary creatures, burglars, and the common disorder there is separation anxiety. So then we have the early childhood, 5 to 7 years. These ones, mostly the principal source of fear are natural disasters, injury, animals, media-based fears, washing deadly cartoons and fights. But surprisingly, the most common anxiety disorder around the 5 to 7 year olds. Then we have the middle childhood, 8 to 11 years. These ones, their principal source of fear is poor academic and athletic performance, and in some of our families, some of our children might be battling with this because I'm sure all of us are aware that the school system has changed. We push these children and want them to get a 4. So the academic pressures are extremely too high. Performance at school is like a must. So that results into problems because they are really trying their best. At one point, I talked to my son and I saw tears in his eyes and says, "Daddy, I'm doing my best." But I realized that the grades I'm pushing him to get are very unrealistic. But sometimes in parenting, we forget and try to go a little overboard. Then among adolescents, the principal source of fear is peer rejection. And the common anxiety problems here are social phobia, agoraphobia, panic disorder. Those are the normal anxieties expected with those age groups. Yeah, prevalence of these neurocognitive and psychiatric impairment, psychiatric disorders in a clinical population of children that is normal, was found to be varying. Generalized anxiety disorder was 2.2. This is a study that we did in a peri-urban setting in Entebbe schools. But of course, it had flaws because one, we only looked at a few schools in the peri-urban setting, and this wasn't representative of the all schools because we have the schools that are in urban, peri-urban, and in the rural. So that was only in the peri-urban. But prevalence of these anxiety disorders among children, adolescents with HIV happens to be 3.2. This is a study that we did. And the 3.2% were those meeting diagnostic criteria, but those who had the symptoms that were enough to suggest that there is an anxiety disorder were 21.2%. And prevalence of generalized anxiety disorder among this clinical population of children, adolescents with HIV was 0.7. Those met diagnostic criteria, but 1.6 met the symptom count. Now, most of these studies have been in the clinical population, but little has been done in the other general population. So regarding the description and diagnosis, we look at the core features, among which include avoidance, that's core. But there's also fearfulness, distress, shyness, expectation of a threat, worry, rumination, anxious anticipation, negative thoughts, physical complaints, difficult with sleep. And usually it has a comorbidity. It occurs with other problems, and there's an overlap between various disorders like depression and anxiety. 80 to 90% have more than one disorder, and 75% have more than one anxiety disorder. So a child may have a generalized anxiety disorder and have panic disorder. 10 to 30% have additional mood disorders, and 25% of young children have an additional behavior disorder. There's an overlap with alcohol abuse, but this happens to appear much later. In the general population, more females, more girls happen to be affected, about 1.5 to 2. in a ratio of 1.5 to 2 as compared to the boys. So this one is more common among girls. Age of onset, usually these begin by mid-childhood to mid-adolescence. So there's an association with a temperament inhibition and fearfulness. Age of onset varies. For animal phobias, the onset can be 6 to 7 years. Separation anxiety disorders is 7 to 8 years. Generalized anxiety disorders is 10 to 12 years. Social anxiety disorders is 11 to 13 years. And obsessive compulsive disorders is 13 to 15 years. While panic disorders, it's 22 to 24 years. In assessment, we usually consider 3 parts: the questionnaires, diagnostic interview, and behavior observations for you to come up with a clue. Either this person meets the diagnostic criteria. So the clinical judgment is very important, but this has to be combined with various other sources of information. So it's important to have a separate interview with the child, most of those above 8 years old. But it's important to know that some anxious kids fake good. They try to mask up the symptoms, while anxious parents may exaggerate symptoms. So it's important to have a separate interviews for the child and for the parent or the caregiver for you to be able to sum up with the other assessments to arrive at a diagnosis. You have to identify the motivation behind the behaviors that are observed or reported, and then determine the primary disorder and treat first. Usually it's important to treat the primary cause first. That may sort out so many things. There are different scales that are used to assess for anxiety disorders among children and adolescents. So it depends on what you want to do. Either it's for clinical purposes or for research or for, or for training. It depends. But one of the most common that we use in clinical settings in these countries are the BDI series: Beck Anxiety Inventory, Beck Depression Inventory. It's commonly used. But we have other measures that are used for measuring anxiety. As you can see, there are so many, but some of these have been adapted for use here, some are not. So when you're using these measures, you have to look at the cross-cultural adaptation for its use in this part of the world, because some of these were developed in the West. In assessment, also we use the KSADS, Kiddies Schedule for Affective Disorders and Schizophrenia. And this one captures both the affective disorders and schizophrenia. And the DISC is a common one also, Diagnostic Interview Schedule for Children. So these are some of them. Yeah, there are several of those that are used. But let's look at the risk and maintaining factors. What are these risk factors and maintaining factors that cause children to become anxious? There is family transmission. Anxiety and inherited temperament runs in families. And sometimes the mothers, fathers transmit this to their children, either biologically or sometimes it's through the parenting, through that environment. You've had children who shout at a slight thing. They say, "Oh my Lord, I'm dead, I'm crushed." They must have learned that from somebody else. So sometimes they exaggerate situations. So it's important to really assess and know what's the cause of this anxiety and is it realistic or not. First degree relatives at risk for anxiety and mood disorders, and transmission of these disorders follows that trend. There are genetic and environmental influences. We have the genetic factors, 40% variance mediated by genetics, and this is evidenced by the twin study, 30 to 40 variance by hereditary, especially high with the general population that's neurotic. So the most studied gene is the serotonin transporter gene, this one. Don't worry about that language. But this transporter gene is the most studied. It happens to have a genetic trend, and in people who have these problems, if you look at this gene, the child and the parent, there is really a similarity. The serotonin transporter genes are very much responsible for most of these traits transmission. Now, there are temperament factors. These are best studied and most clearly established risk factors. We have withdrawing the faith of novelty, lack of smiling, lack of talk, limited eye contact. These are related to the temperament. Close proximity to attachment figures, slowness to warm up to strangers or peers, unwillingness to explore new situations. So partly parenting plays a role in these temperament factors, as you can see, and partly the culture. I know some of us suffered a lot as children. When we were growing up, you are not supposed to look in the eyes of an adult, and some parents still maintain that. And when you did that, you'd be punished for being a bad child. Yet actually now we are training children to be assertive. All my children, even the 3-year-old, has to look me in the face and talk. So we train them to be assertive, but there are cultural factors that relate to the parenting and those impact on the child and adolescent outcomes. In preschool children are 2 to 4 times more likely to have anxiety by middle childhood. There are parental and family factors evidenced by difficult to obtain, but data is not consistent. So parental characteristics can include overprotectiveness, intrusiveness, or negativity. All those impact parental model and communication of fear. Sometimes parents exaggerate fear. You're going to die. The dragon will come and eat you in the night. So when you tell that to a toddler, it increases the fear and might problems. Sexual abuse, physical abuse, family violence are also responsible for maintaining, and they happen to be risk factors for anxiety disorders among children and adolescents. Life events are significant. Increased negative life events. Greatest difference happens to be on dependent events, bullying and teasing, neglect and rejection by peers. I'm surprised that bullying is still in schools. I thought it had stopped, but in most schools among the S2 and F3, it's very common. So those can really be factors that can maintain the problem or be a risk. But there are also cognitive biases, which are heightened by threat beliefs and expectations. Specific to disorder type, decreased with successful treatment, but bias in attention toward threat, bias to interpret ambiguous information. Now, one of the relevant models that helps us to understand these problems better is this CBT model, cognitive behavioral therapy. And it looks at 4 main aspects: the thoughts, the feelings, the behavior, and the symptoms. So when you see the symptoms, you have to elicit for the thoughts what goes on in the mind when the child is acting out like that. Then you associate this to the feelings and then to the behavior. So you look at the physiological symptoms and look at how these are associated with the thoughts, the feelings, the behavior. But sometimes the thoughts can enact a behavior directly, or sometimes the physiological symptoms can lead to the feelings. So these can cross-cut as well. But as you see, this model is helpful in helping us to develop a formulation when we are going to help these young people. In therapy, pharmacotherapy is effective, especially the selective serotonin reuptake inhibitors, but little difference between agents, except for paroxetine, are not recommended. So treatment generally takes 10 to 15 weeks, and 50 to 60% of children respond versus 30 who happen not to respond very well. Medication effects may level off after 8 weeks. So 7% anxious kids discontinue due to adverse side effects. So it's important to monitor suicidality when you're treating these children. But skill-based programs are very good, like psych education, relaxation, exposure therapy, contingency management, parenting. Good parenting can help control most of these problems. Cognitive restructuring, enabling these young people to think well and be able to act well. Social skills and assertiveness training is important. Generally, this skill-based program can take about 8 to 15 weeks or 1 to 2 hours, and it's 1 to 2 hours per session. So it can be either group-based or individual-based. So I think you can see a broad spectrum of this skill-based program with all the components: psych education, cognitive restructuring, in vivo exposure. So you can have a session for the child or adolescent and a session for the parent. So this helps to create to level the platform and be able to support both.
Dr. Mpango, we are losing you.
And the parent expected. Why?
Dr. Mpango, you're not clear. Okay. Hello?
Sorry, it had gone off, but I think I'm on again. Is that okay?
No, we can't
Do you
see
hear
the
me?
screen. We can hear you, but we don't see the screen.
You need to share your screen.
Okay. Yeah. I kindly request to intervention is very shock here. There is clarity or progress regarding everybody in nature. UK find a facility for children. Here they are almost non-existent. So in conclusion, regarding anxiety, this is a promising area that research to keenly study these risk factors very well. The flaws in the studies we've conducted some of them were cross-sectional. So we need to have a longitudinal studies to look at these risk factors very well and be able to turn to realize that the gene environment affects quite a lot. So we need to be very, very mindful about that. And we need to, dissemination of these treatments, and now these can to reach out to that child out there in the local school is an important area that we need to think about. But we need to evaluate these developments and see what. So I'm going to look at the second problem But real with these different adolescents, mood, loss of interest in previous play activity, suicide ideation, thoughts of suicide or death, feeling guilty or ashamed, sleep disturbance nearly every day, loss of weight, appetite, increased physical complaints. Increased physical complaint is significant. Increased school problems, absence from school, poor performance, trouble concentrating, feeling or appearing depressed, sad, tearful, irritable, isolation, injection or failure, fatigue or psychomotor slowing or agitation, alcohol use. These problems are very common. 1% of preschools children happen to be affected by anxiety. Children happen to be about the 3 years and above, because by 3 they start school. 6% of those who suffer happen to be girls and 4% boys during adolescence. But in adolescence, the lifetime prevalence ranges between 5 to 20, with extreme abuse or neglect in some circumstances. Prevalence based on some Ugandan studies here. For major depressive disorder, we did a study in the normal peri-urban schools in Entebbe, and we established a major depressive disorder to be 5.9. A prevalence of depressive disorder in IV. Those who made diagnosis 6.7, 6.9 to 6.7, and this so much. So we've measured so much in the clinical populations and left the other population unattended to the HIV in the diagnosis criteria, but that had symptoms enough to be done. So when you compare this rate 5.1 and this one 5.9, this for us to start focusing in the general population, attend population. Assessments for these, there's many, but we use the Beck inventories quite a lot, which can, there are other inventories, like the children depression is very common. Train most clinics, a very common measure. It's in our guidelines, very clear guidelines that recommend that we should identify those that have depression, but that's not been implemented in most schools. Children happen to be brought to the well, but it could have been possible that the school teachers are told to use this screening instrument to identify. Let us do the in most of those activities, and the clinical interview with the parent. You consider the views of both their explanations. It's important information from teachers on this platform. You see your child for one, that's child for 8 hours. The teacher, the caretaker, those are important people, children and adolescents. So risk factors, depression among depressed parents. Sometimes this is transmitted, transgeneration. A depressed parent is 2 ways. One, the environment. Aloof, disinterested. These children copy a lot. So they can copy what you manifest during your interaction with them, and also have the other gene that they carry. So that's a double portion likely to be depressed. Later, hereditary factors are very, very significant. Criticism. So children from such families are more likely. Parents emotionally unavailable, or like such children whose parents are emotional unavailable are more likely to manifest with a depressive trend. Conduct or learning problems, solutions. This is worthlessness, hopelessness, negative expectations. Adult girls are more at risk 2 times as compared to than the girls. So these symptoms can include the thoughts, things will never work out for me, I'm a failure, no one cares about me, it's all my fault. And sometimes these are, these are evoked by the parents. I've been to some homes and I get shocked, and I remember my mother used to do that. Parents can abuse you as you're nothing. So when you say that person, you're destroying him. You can never be anything. So this thought and can become what we call a grow up, but can give these feelings of anger, those times we have activities, self-harm, and the physical. This CBT model is very good, but it has limitations. We've done a lot of this on children, but its major limitations are mainly 2. 1, to a child raised up in a Ugandan setting, it's very difficult to help them identify what are thoughts like, what are feelings like, what are behaviors like, what are physical, physical feelings like. So it's very westernized and works more for children who are able to read and write, who have gone to school. So that makes it a model that is limited. But if we can translate this into our local dialect, I think it's a good model that can do wonders. It does wonders among the adult population. Perceptions associated with depressive disorders among children and adolescents include view of self as not good, useless, inadequate. Like I said before, I've had parents say this to their children, and especially when there is marital disharmony, the father or mother wants to shoot the spouse, but goes through the child. You're stupid like your father. So he wants to tickle the father, but he does it through the child. You see that. So children are supposed to grow up in an environment that's very good and empowering, and that can enable them to have a positive self-image and be assertive and be confident and be able to perform well, not under pressure, but fairly well. So it's important to look and think about those things. So they view the world as life is a struggle, people are cruel, everything's cruel. They view the future as life will always be this way, there is no escape, I'll never get better. Thoughts associated with depression happen to be automatic, distorted, unhelpful. They are believed by the person who has them, involuntary, they lead to acute distress. Etiology of depression among children and adolescents includes the genetic factors. We've already talked about it, and the early childhood adversity and negative life events, loss of father, loss of mother, children who parent themselves, children who are orphaned, children who are destitute, all those negative factors. Family and relationship factors include a parent who is depressed, of course, can transmit this to the child in two ways, via the genes and also the parenting itself emits emotions. So these emotions are learned and they are taken up by the child. Parental rejection, only modest associated with depression. Children with depression and their parents interact in negative ways, less warmth, and they are more hostile. There are these outbursts, cognitive distortions, and negative attribution styles. And this happens develop much earlier in life and affects the child through the, early adolescence and even later on in life. So it's important to help these children and adolescents have a positive attribution style and have a better way of thinking and looking at things. It's you who makes your child or adolescent to be a winner out there in the community. Success begins at home. Charity begins at home. So some medications are used to treat this depression, like the serotonin selective serotonin reuptake inhibitors. Is more effective than the tricyclic drugs, but meta-analysis shows that medications most effective for anxiety than for OCD. So less effective for depression and for OCD. So concerns about medication are the side effects and the possibility of increased risk of suicidal attempts. Interpersonal psychotherapy is good, which focuses on peer pressure, transition to adulthood, and issues related to independence. On a sad note, the highest suicidal prevalence is observed among the 15 to the 24-year-olds. And on a sad note, we've lost several of them. I can never forget. And some of them have been from our region. We have received children who are depressed in Butabika, and you happen to do whatever you can, but later you get a report that the child later committed suicide. They leave the drugs and decide. And you cannot keep somebody in a psychiatric hospital for life. No. One of our clients that we had was from Ginger. She had just joined university, and we had a long discussion with her, and she told me, "Doctor, I'm not going to take these drugs. They make me put on weight. And now my friends at university laugh at me. They call me all names. They call me pig." And she told me, "No, I can't suffer like this." So I asked her, "How can we be of help?" She said, "No, you cannot keep me here. You with your team discharge me. I know what to do." So we tried to intervene. We even had to keep her for an additional month. But at a point when we had to let her go home. She went to church and went off medication. And later on, after that, just bought a new pickup, double cabin. She went into the garage, went into the roof, and she had to jump, climb on the pickup and hang in the garage. So they discovered 2 days after that she had died. When they were looking for her, they were not seeing her. That's why I say these disorders are very silent. You might have a child who is not complaining, a bit tearful, not talking too much, but is very, very sick. So this girl committed suicide. And even the experts, when somebody decides to commit suicide, we are limited in some ways. The facilities we have here are not that great. One of our clients was challenging me, keeping me here in Butavika is like keeping me in hell. You better send me home. At home, I have my own room, own bathroom. I eat a good meal. So I can decide either take medication or not. It's me, it's my life. So those are the challenges that we get. So this interpersonal psychotherapy is very good. You help a child
Dr. Mpango, we can't hear you. We are losing you. Dr. Mpango.
acquire. Hello? Do you still hear me? Hello?
Yes,
Hello?
you can now hear you. We can now hear you.
Okay, there was a glitch, but it's done, I think. CBT is effective for the Caucasian adolescents and those with the pre-treatment and good coping skill and recurrent depression. So I think it's us to decide which might be a better therapy. Medications are good for the quick fix, but there are side effects. One of the most worrying, especially among the young people, is the putting on weight. These young girls, and you remember we've said it's common among the young girls, they don't want this weight. Some of them even starve, they want to do away with weight. So when they learn that, and there is social media. These children and adolescents use social media more than you and me. They even read about their problems and happen to know the side effects. And when they come to you, they're a little challenging. So you need to have a balanced discussion to look at how you can support them. Psychotherapy is generally only modestly effective with the children and adolescents, but it's us to think about its efficacious within this population. Let's look at another problem related to that: suicide among children and adolescents. But suicide and depression, they are like a brother and sister. In most cases of depression, you must rule out suicide. So they sometimes occur together, and both of them are very, very worrying. They are not easy problems to tackle, and they are very, very challenging problems that claim the lives of many. And this has happened even in this country. Suicide is the third leading cause of death among people 15 to 24 years of age. 17% are seriously contemplate suicide. But so there are those who contemplate, but there are those who complete. Girls have higher rates of suicide. The ratio is 2 to 3.
Dr. Mpango, you're not
compared
clear.
to one complete suicide that
Oh,
sorry, there was a glitch. Do you hear me now?
yes, please share your slides.
Okay. Sorry for what has happened. Do you see my screen? Hello? Do you see my
Yes,
screen?
we can see. Yes, we can see the screen.
Okay, good. So these rates vary, but it's rare below age 12. Suicide below the age 12. It's it increases with age. So in the 10 to 14 year old, the ratio is 1.3 per 100 overall. But it's 2.3 among the boys and 0.6 among the girls. So I think you can see the rates vary and it varies with gender. The 15 to 19-year-old, it's 8.2 per 100 overall, but 13.2 happen to be boys and 2.8 girls. Yeah. So adolescents commit suicide almost every year, even in this country. General risk factors for suicide include depression and other mental health issues, substance. Many children and adolescents are using substances in schools. Prior attempts of the risk factor, family history of suicide, suicide, family violence or sexual abuse, trauma, easy access to lethal weapons, firearms in the homes and families, incarceration, exposure to suicide behavior, guest charged by friends, social media is a challenge. So behavior signs to look for include the depressed mood, extremely children who are anxious or have these depressive disorders happen to be very, very low. Increase in drug or alcohol use, prescription medication or abuse. You look out for those feelings of being a burden or disappointing, waiting to die or killing self. I know there is psychosocial strife. I've known people who have raised up for funds, a lot of pain, paying a lot of money in fees, and he kept saying, I keep starving because I have to pay your fees. So this orphan one day felt like, no, I think I should not continue to be a burden. I should find my way. And the orphan committed suicide, you know. So be careful when you're talking to the young people. They might interpret what you said differently. Yeah. Increase in mental health problems, medications or therapy not working, unemployment is also a factor. Acting angrily, being agitated or anxious, isolating from friends, quitting activities, giving things of value away. So you look out for those. Monitor and pay attention to your teens, peer groups, and social media sites. I'm not sure how many parents on this platform control their children's media sites. You need to consult an IT. There is a way you do it so that every site they check, it comes to your phone and you're able to talk to them and say, today you looked at this, so that they know that you are monitoring, because out of there, they might learn other things. Spend time with them and be involved as much as they can let you in their social sports activities. On a sad note, one of the most most experienced clinical psychologists was teasing me and saying, you academicians and doctors, your children happen to commit more suicide and have more mental health issues than children of other people who are not at that level. And I first denied, but later on, I realized that many times we forget, have time for appointments, for patients, eh, for many activities, but give little time to our children. So it's important to tell them and demonstrate that you love them. This can increase their emotional acceptance, especially the dads. The dads are absent. So the dads need to be present in the parenting and not leave it to the wives only. Be reasonable in your expectations for academic performance. We want a child to get 4 out of 4 subjects in P7 and 8 for 8. But when they ask you, did you get that? No. These pressures were not at these extremes. Where we are is extremely bad. In one of the schools where my children go, parents almost wanted to beat up the head teacher. They were saying, no, but why did our children not get 4 and 5 only? It's like it's a crime to get a 6 and above. So the pressures are extremely too high. So we need to let people have realistic expectations for the academic performance of their children. Focus on character building and emotional stability. Be very quick and decisive regarding drug and alcohol use boundaries. If you see something, say something. For example, news and internet searches and drug paraphernalia. You have to be a parent who is present, not a one who is not available, on calls and being away. So talk as part of the interventions, talk directly to the child or adolescent. Talking to them can encourage them. And some people think that talking to them can make them commit suicide. No, talking to them is very therapeutic. So it's important to talk to them directly. Ask specifically about their situation, feelings, what you have noticed. Ask if they have thought about killing themselves. If so, what was the plan? You need to have this plan, and how would they do it? Make your child or adolescent your friend. Enlist the help of pastors, coaches, counselors, school staff, information and staff. But there is need for liaison, not in isolation. They should be in touch with the mental health experts, because we need to have a balance. Some pastors are radical. They say, put away the drugs, I just pray for you. We need to have a balance. You can go to church, get prayer. Prayer is therapeutic, it is supportive, but you also need to take the medication and take good care of your adolescent or yourself. So if intent is expressed, seek immediate professional help from a licensed mental health professional. Dr. Carol Birungi is a psychiatrist. We have other psychiatrists on this platform. We have Dr. Biraba, we have Dr. Basangwa. Those are our seniors. So if your child has a problem, talk to somebody and see how they could be directed where they can get good support, and don't wait until it's too late. These problems are silent but real. Get a suicidal risk assessment done and develop a weekly plan to address suicide ideation and underlying issues. Have a no self-harm contract with check-in times agreed to. When a crisis, call this number. There's some work being done around Mulago, so we've been using this number to refer those people who are in a crisis to call, and they are supported. Some of our friends have done much work regarding this suicide. And when you call them, they can come in and offer support and care. They have a network. And I think this is a good development currently. 5-10 years ago, this wasn't there. It wasn't there. Remove all hazardous weapons and firearms from the house. Keep up with treatment and medication recommended as long as advisable. Combination of individual and family therapy are usually advised, and these are better outcomes. Do not tolerate drug or alcohol use. Drug alcohol use who are suicidal. Okay. So the last one, as I'm about to end, is obsessive compulsive disorder. This is an interesting one. A condition with the obsessions, repeated urges or ideas that are irrational, intrusive, combined with compulsions. So the compulsions are the behaviors, the obsessions are the repeated urges and irrational thoughts, which are intrusive. These interfere with the person's quality of life and often are in association with other neurodevelopmental or psychiatric problems. Other symptomatic features may include impulsivity, aggressive behavior, sexual obsession, religious rituals. Well, here we are looking at obsessions and compulsions, okay? Some of these are washing continuously, praying all the time, checking the doors all the time, trying to put things in a very strict orderly way all the time. And various fears may arise from hygiene, contamination, cleanliness, and the need for continuous checking and establishment of constant symmetry in their lives. So this is a big problem. It's silent but big. When your child or adolescent has it, you might think it's a joke. OCD is a chronic condition that impacts humans from early childhood through adulthood, with a continuum between obsessive compulsive traits to overt OCD. It's often underdiagnosed, often found with minimal insight in those who have OCD, as well as considerable family accommodation than they enjoy from their families. Older parental age increases risks for some of these neurodevelopmental disorders like obsessive compulsive disorder. So in the epidemiology, it's variably found 1 to 4% of children and adolescents globally. Approximately 4 out of 10 children have obsessive compulsive disorder, happen to develop it, and it becomes chronic. Many seek to conceal their OCD from others. They try to conceal. It's one of the top 10 most handicapping conditions among human beings. It begins in childhood, but approximately 8 in 10 of those developing OCD initiated by 18 years of age. Among children, we have the early onset OCD, which reflects developmental perspectives. Yeah, in the etiology, we look at research reveals underlying factors that relate to these, and mostly they are about 4 or 5. There is the behavior, the neurological, the infectious, the immunological underpinnings. So all these are very important when we look at the etiology. The behavior, sometimes these are learned. If you're a parent who has OCD and the child sees you washing all the time, checking doors all the time, being too extremely orderly all the time, they happen to learn from you. So various psychological and neuropsychological models of etiology describe complex process in which a person learns or is driven to determine what are perceived as errors in their thinking in order to cope with deep-seated anxiety. The role of overprotective parenting styles with rigid rules is significant. A person's perspective that their actions are never accepted by others, and various other adverse childhood experiences continue to be debated in this 21st century. The neurological changes in the neurological functioning can relate to OCD. So the brain imaging studies suggest that there are changes to the cortical structures and circuits of the brain when somebody has OCD. So these are being demonstrated in several studies, and especially the frontal parietal limbic system happens to be affected. So there are alterations in the hippocampus and serotonergic dopaminergic pathways, as well as glutagic system. So brain changes can be influenced by genetics, age, anti-OCD medication. All these happen to become cyclic, but there is the immunological etiology, which suggests linking the condition with the pro-inflammatory cytokines such as TNF alpha and the IL-12. Inflammatory damage to the monocytes can be noted in person with OCD and modified by effects of OCD medication, as seen with the measurements of pro-inflammatory cytokines. The role of the immune system and infection continues to be studied, as with part of pediatric person developing OCD, developing acute disseminated encephalomyelitis, which targets the cerebral white matter. So these are still studies done here. Maybe at some point we shall reach there and do them. But there is another etiological mechanism, the gastrointestinal microbiome etiology. This influences the brain to affect human behavior via the GI inflammation and immunological effects. The presence of the various GI microbes, as influenced by the various internal and external factors, the stressors, can induce or influence such conditions such as depression, obsessive compulsive disorders, and bacteria under study in this group include the beta hemolytic streptococcus and bacteroidetes. So there are still studies taking place, but there is this undoubtable one, the genetic etiology. It's increased 2 times in the first degree relatives. Various genes are under study. An example are those that serotonin transporter gene, those are still under study, but they are being found to be associated with OCD, especially in the first degree relatives of the person who has OCD. Links with OCD have been found, for example, with serotonin transporter, the 5-HTT-LPR. Yeah. Now, in diagnosis of this OCD, inquire about symptoms such as ritualistic behaviors that are repeated over and over, locations that are carefully avoided, and acknowledgement of invasive thoughts or ideas. Yeah. Thorough medical history, including family history, along with physical examination and diagnostic interviews with psychological assessments are important. So there are several measures that we use to identify if somebody has obsessive compulsive disorder. Some are based on the DSM-5, some are still based on the DSM-4. So there are so many measures, but here mostly we use those based on the DSM-4. Some of those based on the DSM-5 have not been fully developed here, but we use this one. The child behavior checklist is used here. We use this in our clinical settings. Yeah. So in management of this OCD, it's important to have a psychotherapy and medications. Substantial evidence supports the use of serotonin reuptake inhibitors, selective serotonin reuptake inhibitors, and cognitive behavioral therapy in the management of OCD among children and adolescents. Psychotherapy includes cognitive behavioral therapy, widely regarded as the first line of treatment for OCD. For mild, moderate cases of OCD among children and adolescents. So CBT has shown comparable and better outcomes as compared to the other treatment modalities. Yeah. CBT for OCD can include a component of psychoeducation, cognitive retraining, exposure and response prevention, Those can help the child outgrow those problems. Other specific components used in pediatric OCD have also been evaluated. A 5 weeks program is effective, and most of these have been done in the other part of the world, but not here. It's often to consider parental involvement as important in this CBT model. Pharmacotherapy, use of drugs in treatment of OCD, has been evaluated. Clomipramine was the first medication to be studied, but showed clinical efficacy in treating pediatric OCD, followed by fluoxetine. Maybe clinicians will tell us which one has worked well for them, but most of the application still relates to fluoxetine. Have also demonstrated the efficacy of fluvoxamine, sertraline, and paroxetine. Related, often higher rates of mild side effects, most commonly nausea, but rarely serious side effects. So response rates, however, vary between 40 to 60, leaving a substantial number of non-responders as well. In conclusion, OCD among children and adolescents is a chronic, remitting, relapsing condition that often persists into adulthood. Despite the fact that medications have a significant role in treatment, current research continues to converge in support of CBT as the first line of treatment, which has a long-term positive outcome for OCD among children and adolescents. So the way forward, many children may be battling with mental health problems that are not recognized. Child and adolescent health policy in Uganda recommend the screening for mental, neurological, and substance related problems among school-going children and adolescents. But just think about the capacity and the resources that can do that in schools. Let's just look in our eastern region. Is it doable? Can money be available for this early screening? Can school teachers be taught? Can we consider task shifting? Who can do that? Who can be responsible? Does every school have a mental health representative or a counselor that can be able to attend to most of these problems early enough and recommend the referral when necessary? We need to determine the epidemiology, the burden of these problems in the non-clinical versus the clinical population, and look at how we can focus and prioritize where to start from. In all these schools, we need to have a public health approach, and I'm sure we have public health specialists here. Those can guide us in how we can do this. Remember, these are our children, and unless we provide them with the better mental service now, the future of our children and their children is bleak. So we need to adapt and develop locally appropriate instruments for screening, monitoring, and assessing these problems. So we've tried to do some work around that. There's an instrument that I worked upon that we commonly use around here, the Child Adolescent Symptom Inventory and the Child Adolescent Symptom Inventory, the progress monitor that can be used in clinical settings. But on a sad or good note, most of this work has been done here in Kampala, in Masaka, and I feel ashamed that I've not done some work in Busoga, where I hail from. But most of these instruments have been cross-culturally validated and used in clinical settings here and research, but not translated into Lusoga for use with the population in the East. So we need to undertake pilot interventions to assess for the feasibility and acceptability and trends to efficacy. We need to operationalize the Uganda government policy. Even this one is in the policy to establish youth-friendly corners. You know, many things are in the policy, but when you come to implementation, It never happens. We have DHOs here. Maybe we could start with every DHO making sure at your district there's one youth-friendly corner. That could be a platform where we could start from. In some of the studies we've done here in Masaka, PG, we've been going through the DHOs and getting to these youth-friendly corners and providing resources and building them so that we attract these adolescents to come for our research, and we look at how we can start from there. But do these cut across? Do we also have these youth-friendly corners being established in the East, or it's only here in Mpigi, in Masaka, in Kampala? So those are things we need to think about. Thank you for listening to me. That ends my presentation, and the floor is open.